Good evening, ladies and gentlemen. The topic of today's lecture is an interesting and new one. This is important in various cancers, especially the cutaneous skin tumors, and has an importance both clinically as well as during examination. So I'm going to discuss and try to explain to you the phenomena of field cancerization. So this lecture will include its definition, the epidemiology, risk factors, outcomes, and treatment. This terminology, the field cancerization, was first described in 1953 when pathologic atypia was identified in clinically normal tissue surrounding the oropharyngeal carcinoma. So it means that the normal tissue that surrounds a tumor comes in the field of that tumor and has a potential to turn into malignancy. So all the normal tissues surrounding the tumor are then called as the field cancerization. The development of subsequent tumors within the field either represent the recurrence of the original tumor or additional or new primary tumors surrounding the original one. This phenomena of field cancerization is applicable on numerous other epithelial tumors, including those of skin. So the cutaneous field cancerization is our concern that occur mainly in areas exposed to ultraviolet radiations. That is the exposed areas. And the ultraviolet radiation leads to the clonal proliferation of p53 muted cells in the field. And these muted cells results in formation of multifocal or multiple actinic keratoses, squamous cell carcinomas in situ, and later frank cutaneous squamous cell carcinomas. So at the cellular level, field cancerization may be described as growth of a mutant clones that creates a field of cells surrounding the original tumor that predispose to the further tumor growth. The accurate identification of patients with cutaneous field cancerization is of paramount importance because it identifies patients who are at greater risk of developing multiple cutaneous squamous cell carcinomas and having poor disease-related outcomes. So the patients who are predisposed to field cancerization are not similar to other patients who are not exposed to field cancerizations. And who are the patients who are liable to field cancerization, we will discuss subsequently. The clinical manifestations of field cancerizations lie in a continuum between a relatively benign actinic keratosis and malignant cutaneous squamous cell carcinomas. Patients with field cancerization have a disease process that behaves differently from those with multiple discrete actinic keratosis. So multiple discrete actinic keratosis can be found in different individuals, but such individuals does not mean that these individuals are having field cancerizations. A lack of understanding of field cancerization may falsely lead clinicians to undertreat the patients who are liable to field cancerizations, and such patients require a more aggressive approach. So among the patients suffering from actinic keratosis, it is imperative that dermatologists separate those who are suffering from the usual actinic keratosis from those who are suffering from field cancerization, so that the approach of treatment is also different in the second category. The risk factors for development of field cancerization include, this is important, number one, male sex, number two, those with lighter skin, people with increasing age, people who are immunosuppressive due to treatment or by disease, and those who are exposed to ultraviolet radiations. Epidemiology. Age. Five-fold increase in actinic keratosis is seen in patients between 70 to 79 years versus those of 50 to 59 years. So as the age advances, the chances of field cancerization increases. Males have consistently higher rates of actinic keratosis compared to women. Males also have 3 times higher prevalence of extensive actinic damage because of their occupation or time they spend outdoors. Body sites. The actinic keratosis are seen exclusively on sun-exposed areas, including the scalp, face, dorsal aspect of hands and forearms. Then fair-skinned people have significantly higher risk of developing actinic keratosis because of their susceptibility to ultraviolet radiations. Then ultraviolet radiation. Both actinic keratosis and cutaneous squamous cell carcinomas are related to the amount of cumulative ultraviolet radiation an individual experiences over his or her lifetime. Occupations with higher rates of daily sun exposure have been shown to have an increased risk of actinic damage and hence field cancerization. Immunosuppression. The risk of actinic keratosis and cutaneous squamous cell carcinomas significantly increases in patients who are immunosuppressed, such as organ transplant recipient or patients with chronic lymphocytic leukemias. Assessing field cancerization. Compared with patient with diffuse actinic keratosis, patients with field cancerization are more likely to have broad and hyperkeratotic scaly lesions, suggesting progression to squamous cell carcinoma in situ or early invasive cutaneous SCCs. So in addition to the factors I have already mentioned before that include the increased age, male sex, unusual ultraviolet radiation exposure, exposure on lesions on sun-exposed areas, particular occupation, etc., those patients who are liable to develop lesions due to field cancerizations have the more hyperkeratotic type of actinic keratosis than the usual individuals. Field cancerization is associated with significantly higher risk of squamous cell carcinomas as compared to those having discrete AKs. Recognition and treatment of field cancerization provides significant cost reduction in subsequent treatments. Given the high morbidity associated with field cancerization, it is imperative that the dermatologists understand this condition and that aggressive management are planned for such patients well in time. The different treatment strategies for field cancerization. The goal of field cancerization treatment is to reduce the risk of developing keratinocyte carcinoma. Selecting an appropriate therapy depends on the degree of field cancerization and number of invasive cutaneous SCCs. Other considerations for the treatment include the treatment efficacy, its cost, the side effects, and patient's preference. Field therapies are preferred because they address clinically visible disease and subclinical atypia. That is, areas surrounding the diseased skin or lesions which otherwise look normal. Then, in addition to the field therapy, there are lesion direct therapies that are useful for lesions that are more difficult to treat than those where histological diagnosis is required. But most of the patients with extensive field cancerization benefit from a combination of field therapy as well as the lesion direct therapy. The field directed therapy. Field directed therapies are those treat therapies which are directed to the clinically normal tissues surrounding the abnormal lesion. And these therapies reduce actinic keratosis burden as well as number of new SCCs formation. The choice of treatment is dictated by patient and physician preference. The first and the foremost treatment for field therapy and field cancerization is 5-fluorouracil, which is a pyrimidine analog approved by FDA for the treatment of actinic keratosis and superficial BCC. So 5-fluorouracil should be given at the areas surrounding the frank tumors. Imiquimod is a topical immune response modifier that is approved by FDA for the treatment of non-hyperkeratotic actinic keratosis on face and scalp. Then a combination of 5-fluorouracil and calcipetrol. This combination has been shown to have a synergistic effect in reducing the long-term risk of SCC. Chemoraps. Weekly wraps with 5-fluorouracil occluded with zinc impregnated gauze, that is ANA wraps, is effective for field cancerization involving the extremities. Ingenol mubitate is approved by FDA for treatment of non-hyperkeratotic AKs. Then conventional photodynamic therapy is 3-drug light combination for treatment of non-hyperkeratotic actinic keratosis. Daylight photodynamic therapy use ambient visible light to activate the photosensitizer. The photosensitizer is applied on the patient and then patient is exposed to the normal sunlight. This approach minimizes pain and allows for exposure of larger fields. After treatment, the photosensitizer is washed from the exposed areas by soap and water, and patient is instructed to wear a sunscreen for 48 hours subsequently. So as a revision, the field direct therapies include 5-fluorouracil, imiquimod, 5-fluorouracil plus calcipetrol, chemoraps, ingenol mubitate, conventional photodynamic therapy, and daylight photodynamic therapy. Then the second aspect of field cancerization are the therapies which are directed specially to the tumor or the diseased areas. These include the cryotherapy, which is a mainstay of treatment for isolated actinic keratosis with its ease of use and good tolerability. Then surgical management. Surgical management may include the shave removal of persistent hyperkeratotic lesion or surgical excision of invasive keratinocyte carcinomas with appropriate margins. Intralesional 5-fluorouracil is also an effective lesional therapy for eruptive squamous atypia, such as eruptive keratoacanthoma, and is a non-invasive option for low-grade cutaneous squamous cell carcinomas. Then last of the field cancerization treatment include the oral treatment. And the oral treatments include nicotinamide. It's a low-cost chemopreventive agent that reduces actinic keratosis and cutaneous SCCs and require no monitoring. Then oral retinoids may be added for patients who continue to form multiple cutaneous SCCs despite of compressive treatment of field cancerization. Then oral Tabine, a prodrug of 5-fluorouracil, is considered in patients with significant field cancerization and high risk of cutaneous squamous cell carcinomas who failed other treatments of extensive field cancerization. So I would like to conclude by saying that the field cancerization implies to formation of potential formation of tumors surrounding the actinic keratosis or cutaneous squamous cell carcinomas. Field cancerization is applicable to people who are in advanced age, male gender, with lots of sun exposure, lots of ultraviolet radiation exposure, and who are immunosuppressed. So all such patients who are at risk of developing multiple tumors need to be treated by field directed therapies, lesional direct therapies, and oral treatments. Among the field-directed therapies, the main treatments are 5-fluorouracil, imiquimod, 5-fluorouracil plus calcipetrol, and other treatments, which also include photodynamic therapy, classical and daylight photodynamic therapy. Then the lesional treatment include cryotherapy, surgical excision, and intralesional 5-fluorouracil. And oral treatments, which include, in addition to the field cancerization treatment, include nicotinamide and retinoids and cefactabine. I hope the concept is little clear in your minds, and hope to see you soon with another edition of my lecture. Goodbye, and thank you very much for listening.